Hey guys, it's Brittany here from My Core Floor, here for part one in our All Things Pelvic Floor 4-part series. So just to give you guys a quick scoop on kind of how tonight's gonna work. What we're gonna do is tonight we're gonna touch on kind of what is my pelvic floor, because I find that so many clients and so many women I work with don't even know kind of that muscles even exist down there, or what their pelvic floor really is, or what it really does, or how it plays into incontinence or pelvic pain issues. So what we're gonna do first is we're gonna chat a little bit about just the anatomy and kind of what I feel like you guys need to know about your bodies that we just don't get anywhere else. And so we'll start with some of that. I wanna chat a little bit about some pelvic floor dysfunction, and kind of do some definitions on that, because I also find that some women just don't even know what kind of, what is something that's considered pelvic floor dysfunction. What should they be talking to their doctor about? What's normal? What's part of aging? What's part of menopause? What's just normal postpartum? So I want to talk a little bit about dysfunction tonight, and then chat about a few things with statistics and numbers, because the other big thing I find as a pelvic PT with women that I talk to and clients I talk to is that women with these diagnoses and these issues feel very alone, because it's a taboo topic and it's not talked about and not really addressed anywhere. And so they end up really not saying anything to anyone and feeling really alone. So I want to, first of all, let you guys all know tonight that if you are having any issues with your pelvic floor, you are not alone. And so we'll chat a little bit tonight about some statistic stuff. And then I had a few people submit some questions beforehand, which was awesome. So we'll answer some of those. And certainly if you guys have any questions as we get rolling through, put them in the comments. I will check them as we go. If you're watching this on replay later on, just give me a hashtag replay in the comments. And if you have questions as you're watching it on the replay, just submit them in the comments, because before we go live for our part 2 in this series, which is going to be on Thursday, and in part 2, we're going to chat more on things related to incontinence and specifics with incontinence. Part 3, we'll address pelvic pain issues, and part 4, we'll kind of do a little bit of an overview and a mishmash of some things. So if you're watching on replay, don't feel like you can't have your questions answered. Submit them in the comments, and we'll include them in the part 2 video coming up on Thursday. So we'll go ahead and get started. And like I said, if you have questions as you go, comment below, let me know, okay? So I have my pelvis, because I feel like you can't understand the pelvic floor unless you've looked at the anatomy. So this is you guys, if you were looking at someone from the front. So pubic bone is here in the front, spine is in the back. These are your pelvic bones here. These holes you see in the pelvis are your hip sockets, so where your hip joint or your femur would come out of. And that's kind of your pelvic ring is what we call it. I'm gonna turn it this way because I feel like it's easier to show the inside. But if I tip the pelvis and you look inside, what you see is what looks like a soup bowl of muscles. That's your pelvic floor. So support system, colon, uterus, bladder, rectum, all of your internal organs sit within this cavity, and they're actually held up from the bottom by these pelvic floor muscles, okay? The big thing I like everybody to always know, and that I like to point out specifically, is that if you look at this pelvic bowl, the muscles attached to the tailbone and to the base of the spine. So anyone with any sort of back or spinal issues, that can actually contribute to pelvic floor dysfunction, or vice versa. Pelvic floor issues can actually lead to back pain and back issues. And certainly I've had a lot of clients over the years who have had tailbone fractures either during delivery or they've had a bad fall. And that also is a huge contributor to pelvic floor dysfunction that people don't realize. So the spine plays a big role in what happens to the pelvic floor, and vice versa, pelvic floor can play a big role in the spine. This muscle that you see that kind of flaps over this soup bowl on both sides is actually your hip rotator. So it controls the hip rotating out and in. It's not part of the pelvic bowl, but because it sits kind of right on top of it, it's this kind of flappy muscle here that I'm showing. It has a really direct impact on how the pelvic floor functions. So what that means is that hips and what goes on at our hips plays a big role in pelvic floor function and dysfunction. So if you're someone with a chronic history of, deep arthritic type feeling hip pain that just doesn't ever seem to go away, bursitis, tendonitis, hip fractures, any of those things can actually also be contributing factors to pelvic floor dysfunction, or vice versa. Sometimes the pelvic floor can actually mimic or cause referred pain and symptoms in the hip that look like other things. And so if you're somebody who had a hip diagnosis of hip pain and something, and it just hasn't gotten better over the years, you may want to look into some pelvic floor work, because that actually could be the cause of your hip pain. I've seen a lot of women over the years that relationship exists. Pelvic floor then attaches up in here, right on the pubic bone, which is where your abdominal muscles would come down and in. So if we were kind of showing from the front again, the abdominals come down and in. The groin or the adductor muscles come up and they all share that common attachment, which means that if you've had a C-section or you've had abdominal surgery and you have scar tissue in through anywhere in the abdominal cavity, that actually can influence your pelvic floor function, as well as any sort of groin tightness or groin strains over the years. Just if you're somebody who just has had bad flexibility and you feel like that's why your hips always hurt, that can actually be related to pelvic floor dysfunction as well. So what I tell people is that your pelvic floor is really at the mercy of everybody in this ring. And if somebody in this ring isn't doing its job, guess who can pay for it? The pelvic floor. And often that's what I find is the case with a lot of people with pelvic floor diagnoses, is that it's not the pelvic floor's fault. The pelvic floor doesn't just decide to stop working after a certain number of years. If we go back to thinking about like our kids and potty training, those of you that have kids, we potty train our kids at 2. We don't ever sit down and show them this model. We don't ever teach them Kegels. We don't ever kind of show them how it works or how it attaches, but magically they potty train. And when you start having sex, no one again sits down with the model and explains it to you. But those muscles magically work. They don't just decide when you hit 40 or when you've had a baby or when hormones start to change and you're going through perimenopause or menopause to just stop working. There's a reason that they stop working. And what my job is as a therapist is to figure out why they stop working. And so that's a lot of times what I will look at when I'm working with individual clients, is how their pelvic floor is working in relationship to the rest of their body. If I don't look at the rest of their body, I can't really get down to finding the real reason that their pelvic floor is not working the way that it should be working. And so one of the big things I like to show people, and once I kind of give them the basic anatomy tour, is that there's 3 major muscle groups that make up the pelvic floor, okay? I don't care if you know the names. What I want you to know is that if you actually were to look, and I'm not sure if on this video I can really show it as well as I'd like to, but this first group of muscles here in the front, this darker red, there's actually lines in the muscle, and I don't know if you can tell that on the video, but the lines actually run vertical, okay? The significance of those lines and why I like to point them out is that because those lines run vertical, those lines represent your muscle fibers and how the fibers run. So because they run vertical, what that means is that your pelvis has to be able to move forward and back in that same vertical plane in order for that part of the pelvic floor to start kicking in and activating, okay? So let me break this down. It gets a little easier if I use the bicep, because a bicep's a muscle we all kind of get and we can see. So if you want to get a strong bicep, you grab a weight, you start doing curls, okay? The reason your bicep gets stronger is because as you curl up, the muscle shortens. As you curl down, the muscle lengthens. And as you go back and forth moving the arm, it creates this accordion type effect that will actually build up the muscle and build up the strength. If you walked around all day holding your dumbbell like this, I can guarantee your bicep will not get stronger. If you walk around all day holding your dumbbell out like this, your bicep will not get stronger. The arm has to move in the direction of those fibers in order for the muscle to start strengthening and to start working. Same thing happens, guys, with the pelvic floor. It's only a group of muscles. It operates exactly the same as all of the other muscles in your body. So because the muscle fibers in that first group run vertical, hi Cher, then the pelvis has to move forward and back. But the pelvis isn't moving by itself. That means the spine has to move forward and back. It means the hips have to move forward and back. So in order for just that first group of muscles to activate, you need this kind of motion through your pelvis and through your hips and through your spine. Now, because it's a bowl, if you look at that second group of muscles, the really dark pink, and again, I'm not sure if you can tell on here that there's lines kind of running, they start running a little bit more sideways, okay? Because it's a bowl, so as it wraps around. So what that means is because those fibers run more side to side, is that your hips and your pelvis and your spine actually have to be able to move side to side in order to get those muscles to kick in and activate. Now, the last group of muscles all the way in the back, okay, and these ones are a little trickier to see, those muscle fibers actually wrap around and run horizontal. And if you were to see them on this model, and again, I'm not sure if you can really tell on the video, but they actually run perpendicular to the ones in the front. And so they don't activate as well with forward back motion. They don't activate as well with side to side. They actually require rotation of the hips and the pelvis and the spine to activate. So in order for your pelvic floor to kick in all three major muscle groups, you have to be able to move well forward and back. You have to be able to move well side to side. And you have to be able to rotate. Now, the cool part about the pelvic floor is that there's actually a fourth way to activate the pelvic floor, and that's also vertical. It's the only group of muscles in the body that actually activates in a fourth plane of motion. So because the muscles sit like a soup bowl, and I like to just show this one with my hands, as you go down into a squat or a lunge, the muscles will lengthen, and as you come up out of the squat or lunge, the muscles will contract. A Kegel is also a vertical contraction of the entire pelvic floor, okay? So here's what I'm gonna tell you about Kegels. I don't do a lot with Kegels. If you check out my core floor, or if you've been in this group for a while and you're looking at the exercises, there hasn't been any week that's been a Kegel week. I don't teach them. I feel like I shouldn't say that. Occasionally I teach them. There are some times in some places where Kegels can be effective, but most people know about Kegels. That's kind of the only thing people hear from their doctors oftentimes, or from magazines, or their friends, or their parents or grandparents. But if the pelvis has to move here and here and here and here, that means that vertical contraction is only 25% of how that pelvic floor actually has to be able to work. So you can be awesome at Kegels and you still might be having a little bit of leaking, you might still be having pelvic pain, because if you're not moving well in those other directions, then your pelvic floor can't function fully. And so I always like to explain to people, because they'll come in or they'll send me a message and be like, I've been doing my Kegels and I'm still leaking. I tell this story all the time. I don't think I've told it in this group yet, but in my 20 years of practice, when I did an internal on this woman who was in her late 70s, she had to date the strongest Kegel I've ever seen in my entire life, or felt, I should say. It was literally like a suction cup. Her pelvic floor was like a suction cup. I finished her exam and she said, see, I've been doing my Kegels. She sat up from the table to get changed after the exam was over and she peed all over the table. And it was surefire proof that Kegels are just not the only thing your pelvic floor needs in order for it to activate. And that, for me, with my core floor, is one of my biggest messages that I'm always trying to get out through this group and through my membership, is that there's more that you have to be doing other than Kegels if you want to get full function of that pelvic floor. The other cool part about the pelvic floor is that it's made up, these muscle fibers are made up of both slow twitch muscle fibers and fast twitch muscle fibers. So what that means is that your pelvic floor basically has to train for a marathon and it has to train for a quick sprint. So the slow twitch muscle fibers respond more to endurance type of training. So that's where if you're in the car and you really have to pee, you want those muscles to have that ability to kind of hold on a little bit longer so that you can get to the next rest stop. But you also want them to be able to fire quick, where if you have a sneeze coming on or an unexpected laugh or a really bad cough, then you want them to be able to quick contract and close off that urethra to keep it from leaking out. So the pelvic floor also has to be trained at multiple speeds. So you have to do long endurance training. So higher reps, longer, deeper ranges of motion. But you also have to do these really short, quick ranges really fast to be able to fire those fast twitch fibers. So again, it's not just about doing a Kegel. It's about multi-direction and it's about multi-speed and multi-depth to really get the fibers to train in all ways, okay? Just to touch on, so when you hear pelvic floor, these are the muscles that people are usually referencing. It's these deep pelvic floor muscles that support the organs. But there's also a group of muscles superficial. So if I reattach the vagina back onto the pelvis, okay, what I like to point out to people is that there's also 3 major muscle groups on the outside of the vagina that is part of what they call the superficial pelvic floor. And these muscles here, so there's one here, and one across the bottom. Their primary role is actually with sexual function. So helping out with orgasm and with erection and just overall support to the pelvic floor. So if you're somebody who's experiencing pain with sex, these superficial muscles could actually be more of the problem than the deeper muscles. And when you do a Kegel, if you've been doing your Kegels, that doesn't get these superficial muscles. So I always like to point them out, and we'll chat more again in part 3 when we go more into kind of the pelvic pain piece of it. But there are muscles actually on the outside of the vagina as well that need to be looked at and need to be addressed, especially if you're experiencing pain with intercourse or pelvic pain in general, okay? So a little bit about pelvic floor dysfunction, okay? There's a lot of diagnoses out there. There's stress incontinence, there's urge incontinence, there's overactive bladder, there's endometriosis, there's pain with sex, there's vaginismus and vulvodynia, which are all pelvic pain diagnoses. But as I started to mention before, that I really want to touch base with you guys on is that there's a lot of things that happen with women that are not necessarily, red flag pelvic floor, that I want you guys to know about, so that if you're having some of these issues, you know to talk to your doctor, you know to reach out to me. The cool thing about this group is that you have access to your own pelvic floor PT. I'm here, use me. Send me a private message, comment below on the video, shoot me an email, whatever you're comfortable with. Ask the questions, because low back pain can be from pelvic floor dysfunction. Hip issues, hip problems, tailbone pain, abdominal and GI issues can actually be related to pelvic floor. I've seen a number of women over the years who actually have gone through all this GI testing and colonoscopies, and it actually ended up being pelvic floor issues. The pelvic floor can refer pain because of that attachment that sits near the top in the front here. It can actually refer pain into the abdominal region. So abdominal pain that's maybe nagging or ongoing, that might feel GI, but yet you can't quite figure out as you go to the doctor and you run through these tests what's going on. That could actually be pelvic floor, guys. And so women need to know what these symptoms are and what that pelvic floor is responsible for, so that you guys can get the help you need. I just read a study actually earlier today that said when they did this study related to pelvic pain, and they did a survey and asked a bunch of women, that they found that 30% of the women in the group actually had pelvic floor symptoms that were unreported and never diagnosed. So there's a huge number of women out there that are going around thinking that this is kind of their lot in life. I mean, that is actually words used by one of my clients one time. She said, I just thought it was my lot in life, that I just wasn't able to have sex anymore. And that's not true. You don't have to live with these things. My big statement is always, just because this problem is really common in women, and there's a likeliness of it in women because of our hormones, because of pregnancy, because of postpartum issues, because of injuries. There's reasons that as women, we are more set up or more prone to having these issues, but just because it's common does not make it normal. There's a big difference between common and normal. And I feel like that's the big thing that I'm always trying to let people know, is that we need to talk about this. Women need to know more. They need to be educated so that you guys can get the help you need, so that you're not walking around having to wear a pad or a diaper, that you're having to watch on the sidelines while your kids are jumping on the trampoline and they want you to come play, but you can't because you can't jump without peeing. Where you're avoiding having sex with your partner or making up excuses because it hurts. All of those things are not okay, and they're not normal. And I don't care what age you are. There is never an age where it's okay to pee your pants. And there's never an age where it's okay to not be able to have sex and enjoy that intimacy with your partner. I don't care if you've been through menopause. I don't care if you've had 10 children. I don't care if you're 85. There's not an age. And that's part of the myth that I love to bust, is that there is this common acceptance in women that just as we age, it's just kind of is what we have to live with. Nothing drives me crazier than the Depends pads commercials, the fancy underwear that you can wear when you leak, and they're dancing around. No one wants to dance around wearing a pad. I mean, truthfully, like, that's what they want to advertise, but there's no reason to dance around wearing a pad, because there's solutions that are out there. Women just need to know what they are, and they go far beyond doing a Kegel exercise. So there's my mini rant on the side. That's my soapbox. So let's give you some statistics. I want to give you guys some numbers, because if you're having these issues, I can guarantee you are not alone. So statistically right now, it is said that 1 in 3 women are currently experiencing problems with urinary incontinence. That said, some research shows that it's actually closer to 50% of all women, because of studies like I just told you about. It's not being reported. So they're not telling their doctors, they're not circling it on the questionnaire at the OBGYN physical, or it's just not even being asked of them when they go to the doctors. So it's probably closer to 50% of all women that are suffering with some form of incontinence or leaking. And yes, ladies, incontinence is 1 or 2 drops that comes out on the way to the bathroom, or 1 or 2 drops that dribbles out when you're laughing really hard with your friends. When we hear incontinence, we think of like our great-grandmother in the nursing home wearing a big diaper. Incontinence is any amount of unwanted leaking, and that is 1 or 2 drops that comes out. That is actually considered the beginning of pelvic floor dysfunction, so don't fool yourself. That is it. So that said, 1 in 3 women are also being reported to be suffering from some degree of pelvic pain, whether it's from endometriosis, whether it's from vaginal disorders such as vulvodynia or vaginismus. 1 in 3. So if we combine even the lower end of those statistics, I mean, we're looking at, I don't know, more than 60% of all women, 66%. If we say 1 in 3 are having incontinence and 1 in 3 are having pelvic pain, we're looking at 66% of all women are suffering from some degree of pelvic floor dysfunction. Think about you and your group of friends, if you're all hanging out. If you haven't talked about it, you should, because I guarantee with numbers like that, it is somebody that you know that's going through it, okay? You are not alone out there. In addition, it said that 3.3 million women just in the United States alone are suffering from organ prolapse. And we'll talk about that in part 2 on Thursday night when we get into the incontinence. But that's where your vaginal or your organs can actually start to drop into your vaginal canal. So the bladder can drop down. The uterus can drop down. The rectum can start to drop down and push on that vaginal wall. And women will start to experience symptoms such as heaviness and incontinence. They feel like they're sitting on a tennis ball. It's really uncomfortable. 3 million women are experiencing this, ladies. You are not alone. That said, incontinence symptoms are also more likely in women than men, twice as likely actually in women than men, which again, like I said before, that's kind of my last statistic I'll leave you with, but has to do with hormones, has to do that we're the ones that carry babies, go through pregnancy, trauma of delivery, but also has to do with just the anatomy itself. Our urethra is shorter. The men's urethra is obviously longer, and just that anatomy piece alone actually makes us more likely to develop problems with incontinence overall. That said, don't let it fool you. This is not about men tonight, but male pelvic floor dysfunction is a very real thing, and if you think women are not talking about it, men are really not talking about it. So conversation for another time. Just wanted you guys to know that that is actually a thing. It's just not brought up as much because it's, again, not quite as common as it is with females. So 20 minutes. I was going to try to keep this under a half hour for you guys so you guys weren't sitting here having to listen to me chat this whole time. But I'm just going to grab my questions. So people had some questions beforehand, which was awesome. So I'm going to answer a few of those for you guys. If you have any other ones, throw them in the comments, or if not, like I said, if you're watching on replay, put them in the comments later and I'll address them on Thursday in part 2. So one woman wrote into me, are there certain professions that are more likely to develop pelvic floor issues than others? Awesome question. I've actually been doing some looking into this myself, and based on what I've seen clinically, just working one-on-one with people as well as in my groups, and what I am finding is that nurses and teachers have a very high likeliness of pelvic floor dysfunction compared to other professions. And I actually think for very similar reasons. If you think about a nurse or you think about a teacher, their day is spent serving other people. Their schedule is dictated by what's going on with other people. They don't get to just decide, oh, I want to take a bathroom break, or I'm going to go get some more water. And, you know, they don't kind of have the freedom or the flexibility to just do those things on their own. Their schedule is dictated by taking care of others and what's happening around them, either in the classroom or with a patient or in the operating room. And so nurses and teachers are a really high likeliness for developing pelvic floor dysfunction. So if you're a nurse, if you're a teacher, and you want more info on that, I am going to touch a little more on Thursday in the incontinence piece of it. But I have some strategies that I've been trying to play around as I've done some customer interviews, talking with nurses, talking with other teachers. I actually, a couple weeks ago, just taped a podcast with my friend Dawn Pensack for her Common Resilient Teacher podcast. And we did an entire discussion on teachers and incontinence issues as well as pelvic floor dysfunction. So when that airs, I'll also let you guys know so that you can check it out. Next question. I had a C-section, so do I have to worry about getting any problems later on with pelvic floor dysfunction? Sadly, yes. I have had women that will ask, if I ask my doctor to do a C-section, can I avoid these issues? Or I've had one, so does that mean I'm never going to get these issues? I wish I could say yes, ladies, but unfortunately, no. There is certainly trauma that occurs during a vaginal birth that will make you, again, more likely to sometimes develop pelvic floor dysfunction because there can be tearing, there can be tailbone fractures, there can be stitches, you know, all those things that can actually scar tissue that develops that can contribute to pelvic floor issues. That said, just pregnancy alone for 9 months actually will overstretch and lengthen the pelvic floor as the pelvic floor is supporting the baby. And so the pelvic floor will actually weaken over the course of 9 months just by being pregnant. So even if you've had a C-section, it doesn't save your pelvic floor. There was some original thoughts that would kind of, in a few years ago, there were some thoughts of, let's all do planned C-sections because we'll save our pelvic floor. But unfortunately, it doesn't work it doesn't work that well. It doesn't work that good. It's not that black and white. And again, I feel like more so than even the fact that as women we are pregnant, and whether we deliver a C-section or we deliver vaginally, it's really not so much the method of how that baby comes out, but really the mechanics of how we move and how we take care of ourselves during the pregnancy, which is really huge. As well as, and that's probably one of the things I'll get into in one of maybe the 4-part where I have some kind of miscellaneous stuff I want to talk to you about, but how we take care of ourselves during pregnancy, what we do for ourselves postpartum, that really will affect our likeliness for developing pelvic floor dysfunction, not so much the method of which the baby comes out. And so we'll chat a little more on that too as we get going. Is stopping my pee when I'm going to the bathroom a good way to strengthen my pelvic floor? No. We'll talk about this a little more next week, or next part 2 on Thursday as well. But when you stop and start your pee, and again, I'll tell people it's okay to try to stop and start your pee to see if you have the control to be able to just stop the flow. If you were to start leaking, can you kind of quick react and squeeze that urethra shut? It's okay to check it once in a while. It is not a good way to practice exercising your pelvic floor. And the reason is that as your bladder fills, it'll start to stretch, and it will send signals to your brain to let you know, like, hey, gonna have to pee soon, or hey, I really have to pee, real soon. And if you start peeing and then you stop the flow, your brain and your bladder signals actually start to get confused, because your brain is like, wait a minute, I thought you were full. I thought you had to pee. Now you're stopping. Now you're starting. And you actually can start to train your body into developing urinary urgency, urinary frequency, or urinary incontinence issues. So stopping and starting your urine flow is definitely not the way to strengthen your pelvic floor. Again, I'll tell people, if you occasionally want to test it and see kind of if your pelvic floor is getting stronger, if you could do a quick stop if you had to, that's okay. Making it a regular habit or regular practice is not a good thing for you guys to do. Is there something that I can do for myself or for my daughters to prevent them from getting pelvic floor dysfunction? Awesome question. I read an article last week that actually was a woman talking about remembering her first incidence of urinary incontinence at the age of 12, running in a middle school cross-country race. It is happening earlier and earlier. There was a study done with college athletes, Division I, and I believe it was 40% of them were reporting some form of urinary leaking or incontinence during their sport. These are women who have not had children. They have not had traumatic births or anything that, haven't had hormonal changes, perimenopause changes. They are just normal 18 to 22-year-old women. Even younger, 12-year-old middle school girl running cross country. What we're doing as a society is sitting more and more and more. So if you think about our kids in school, they're sitting for 6 hours. Recesses are being cut. Gym classes are being cut. Active play is being reduced and cut. And that actually is setting us up and setting our kids up for problems with their pelvic floor. And so it's really, again, another, soapbox of mine, but movement is so important. So if I had to stress anything about preventing it for yourself or preventing it for your kids, get them up and moving, and multi-directional play is fantastic. We go back to that pelvic model, and I talked to you guys earlier about how important it is for everything to move in 3 directions. Think about a toddler who's potty training, 2, 3 years old. What are they doing? Up, down, twist, turn, crawl, dance, laugh, jump off the curb, climb on the step. Their pelvises are constantly moving. What do we not do as we age? What do we not do as we start getting into school? We're sitting more and more. And then you layer on technology, and kids are sitting more to play video games, and they're not outside as much. And, there's multi-factors that come into that, but movement is really the key. And so if I had to answer the question of what can you do to help prevent it for yourself or for your kids, it's going to be to get up and move in multiple directions. Dancing, don't just walk, do like some little sideways walks, some karaoke steps, squats at various ranges, all of the things you guys see every week that I post in here, all the things that are in my Core Floor membership, multi-directional movement at varying speeds, varying depths. Get those kids moving, get yourself moving. It's really easy to just be like, I don't have time, and I get it. I have 2 kids, I'm working on growing this membership and this business and getting, information out to more and more women. It's busy and it's crazy. And usually as women, we are the last on our own list. We make sure that everyone else in our lives is taken care of, whether it's kids, spouses, parents, siblings, friends. We always put ourselves last. It does not take a lot of time to give your pelvic floor what it needs. So literally 5 minutes a day or a couple minutes a day is better than doing nothing. And if you start making that a habit, excuse me, your pelvic floor is going to start to kick in and it's going to start to activate. It's like riding a bike. Pelvic floor learned what to do when you were 2 or 3 years old. If you start giving it what it needs and you start creating the movement and the blood flow and the activation, it's going to start to kick in. It's going to start to do what it has to do. So that's all my questions for tonight. I don't have any more coming in on comments. So super psyched for all you guys that joined in. Steph, Deborah, Katie, Cher, Liz, Kaylee, thank you guys. Anybody who, again, is catching it on replay, feel free to don't feel like you can't answer or ask a question. I will answer it in part 2. We're going to jump on again on Thursday night at 8 o'clock. The topic will be incontinence and things related to prolapse. We'll touch a little more on the nurses and the teachers thing. And so hop on and join us. I'll send out a reminder again to everybody to let you guys know about Thursday night. But giving you a heads up now, Thursday at 8, we'll be chatting a little bit more about bladder health and specifics on incontinence and some things you can do to just start getting that pelvic floor kicking in to help out your bladder more. All right, guys, hope you enjoyed this and hope you guys have an awesome rest of your night and enjoy the holiday tomorrow if you're off. We'll be back on Thursday. Talk to you guys soon. Take care.